Hello everyone, can everyone see me and hear me? And just pop in the chat if you can. Yeah, there we go. I think it was just to press live. I think we're still waiting on another moderator. However, if they don't come in like the next 2-3 minutes, we'll get started. Someone should be joining in the next 2 minutes. I've just got a text about it. So then we can get started. All right, we'll just get started then, and they'll join whenever they're able to. So, hello everybody, my name is Waleed. I'm a FY2 doctor at Heartlands Hospital, part of UHB. I'm currently doing a job in cardiology, but I've also worked in acute med and in respiratory. And today I'm just going to be doing a talk on respiratory emergencies. So, respiratory emergencies are something that you'll encounter whether you're on ED or as part of the acute medical team. So that's basically involving any medical job that has on-call commitments. One of the most common presentations that you'll see is respiratory related. So before we get started, I just wanted to say that I'll try and make this as interactive as possible as well. So utilizing the chat feature, there'll be a couple of questions in there. Just feel free to ask any questions at any time as well. I think the moderator's joined as well now, so we're good to go. So based off the UK MLA curriculum, these are the conditions that are listed as core respiratory emergencies. So that includes acute bronchitis and respiratory failure, which are often kind of secondary to the other ones in there. And then asthma and COPD, so your obstructive airway diseases. And then also pneumonia, which is very common, and then pneumothoraces and pulmonary embolisms that you kind of want to know what to look out for as well. And then finally, you've got respiratory arrest, which is more down your ALS algorithm, which we won't really be touching on in this talk, but it's important to know that that can be the end result of these conditions, and it's something that we're looking to avoid, of course. So with that, we'll move on to the first case. Just before I do that, just to confirm everyone can hear me and there's no issues with that. Also gets me to use the chat feature to see if it's working.
Yep, yeah, I can hear you.
All right, excellent. So let's get started then. So the first case is something that you'll see quite commonly, a 19-year-old male presenting with a background of asthma and presenting with shortness of breath. So in the history, you get the fact that there's a 1-day history of progressive shortness of breath, and he's been generally feeling under the weather before that for a few days. So as with any patient, you want to, in the acute setting, approach it with an A2E assessment, and I've written one out there. I'll give you about 30 seconds to just read through that. And then my question is going to be, what are some investigations that you'd kind of want to do in this scenario based off the history that you've got and the assessment? So just drop any suggestions in the chat box, and then we can kind of talk about some that I thought of. Mm-hmm. Yep. 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 So that's all pretty reasonable. And with regards to someone who has come in with a background of asthma, I think a peak flow is a really good shout as well. So I've outlined three that are kind of pertinent to this case. Of course, you do an ECG as well, as you've mentioned, and it would probably show tachycardia given the heart rate's 113. So these are the investigations that you find. So we've done an ABG, which has shown an acidotic picture, a respiratory acidotic picture, and then you've got a peak flow there and a chest X-ray. So with all of these kind of investigations in mind, and given what we saw on the previous slide, how do you think we might categorize what's going on here? And that'll kind of also help us with management. Does anyone know what kind of guidelines we'd use to try to categorize this? I don't know if there's a function of like opening your mic on this as well, if anyone wants to just shout out, or otherwise you can just drop it in the chat. Okay, so yeah, we're looking at peak flow reduction for sure. Anything else that kind of will be criteria that will guide us to what we're looking at here? Any other investigation findings, perhaps? I'll just pop up the previous slide as well, in case there's anything in there. Yeah, so that's really good. Yeah. So the way we kind of classify asthma, especially using the BTS guidelines, is into your moderate, your acute, your moderate acute asthma, your acute severe asthma, your life-threatening asthma, and then near-fatal asthma. Now, kind of looking through this, we can see what are we trying to pick up on that will kind of guide us to how bad is this asthma exacerbation, because that's what we're looking at here. So we'll have a look at the observations first of all. So we've got a RESPs of 23 with O2 sats of 93 on air. So we don't have an oxygen requirement right now, which is good. You can hear a wheeze on the chest, and the breathing is labored. So again, you're kind of worried about tiring there. With regards to D, that's really important, is the struggling to complete sentences as well, which gives you a good marker as to kind of how they're dealing with this and how bad it is. And then some of the further investigation findings, you've got a 42% peak flow rate, and then that PaCO2. So we're not on oxygen, and the PaO2 is 8.7, but we are looking at a potential type 2 respiratory failure picture coming along. Another important thing to note about this is what we've got right now is a respiratory acidosis, which is kind of a bit late stage for asthma. So originally, if you can kind of think about the exact mechanisms of it, with asthma, you're going to be breathing a lot more, you're kind of having a higher respirate, and that's actually going to cause respiratory alkalosis first, because you're kind of blowing off the CO2. And it's only as you tire is when you start, getting hypoxic as well as keeping in the CO2 as well. So although that CO2 is normal, that's actually a bad sign. And that's reflected quite well in the guidelines. So as you can see here, although the peak flow is 33 to 50, which would be acute severe, the reps are actually below 25. I think the heart rate is above 110. And that inability to complete sentences does tick the criteria for acute severe. The reason why this is actually a life-threatening exacerbation is because of that normal PaCO2. So that's really important to look out for in these scenarios. And it's something that once you're kind of as part of the acute medical team or in ED, that's something that we always do keep an eye out on, because that's a really good marker for, okay, this is a life-threatening asthma exacerbation and we need to manage it as such. So, speaking of management, what are some of the things that we'd use to manage? I think someone mentioned one already a bit earlier. But what would be the management in this scenario where you've got a life-threatening asthma in front of you? Yeah. So we'd definitely start with some salbutamol. Definitely. Anything else? Yeah. You'd give at least one dose, a stat dose of a steroid. Okay. And then that's kind of a nice ladder that's been put there by Emily there. So, and that's kind of exactly what I've got on the next slide. So with regards to the acute management of asthma, and now I probably should have said this at the start, but not only is this useful in kind of your ED placements or your acute medical placements, but also if you're doing a ward cover as part of any medical surgical job, you might be, get a bleep at 2 a.m., 3 a.m. Oh, this patient's got really breathless. And you do want to be able to initiate that initial management before escalating to a senior. So with asthma, oxygen if hypoxic. So this guy is 93%. He's tiring a bit, so maybe we'd think about it in this scenario. Nebulized salbutamol and nebulized ipratropium bromide would be your mainstays, and that's what you'd kind of start with. With regards to nebulizers, with salbutamol, you can give it as continuous over half an hour, but not everywhere has that. So then in which case you'd kind of get back-to-back nebs. A stat dose of pred or IV hydrocortisone, depending on if they're able to tolerate it orally. And then after that, we move on to a single dose IV magnesium sulfate infusion, or as you mentioned, theophylline and things like that. However, then you're getting into the realm of, clearing that with a senior first, whether that's the med-reg or whoever your registrar is at that time. And then also antibiotics if suspecting a bacterial infection as the trigger, but I'm very I'm saying that right at the bottom in the sense that often what you will get is a viral exacerbation of asthma. In fact, I'd probably say that's one of the most common things I've seen in the past few months especially, is people getting a viral infection on a background of asthma and then having that very similar history that I was just talking about of feeling under the weather for a few days, and then the asthma gets exacerbated and they have this progressive shortness of breath, which is often not relieved by inhalers. A similar presentation that you'll get is COPD. So an infective exacerbation of COPD will often present similarly, and it does look like asthma in the acute setting. You'll have a wheezy chest. You'll often, have the patient having difficulty breathing, and then if you do a blood gas, you might see and type 2 respiratory failure, stuff like that. But in terms of differentiators between asthma and COPD in that acute scenario, I guess the things that you'd be looking out for is significant smoking history. So with COPD, you will often see it in people who have been long-term smokers with a high pack year history of smoking. You will also have, and this is not true for all cases, but with COPD, especially in people who have poorly managed COPD, they may have chronic shortness of breath, which has just got worse. And that's why they've come in, rather than having this acute onset shortness of breath when they're usually completely, breathless, not breathless at baseline. And then seasonal diurnal variation, which are kind of hallmarks of asthma. And then having a productive cough at baseline already is also something that would make you think COPD over asthma. With COPD, in terms of management, with that chest x-ray or whether you go to CT chest afterwards, there can be changes on that imaging, such as malignancy or bronchiectatic changes. So that's something to kind of look out for. But again, I guess that's a bit further down the line. But I mean, I guess with a malignancy, you might see that in the short term as well. So it is an acute thing to look out for. Now, management, similar. You are going to give that 5-day course of steroids. You are going to give your nebulizers. However, the only other thing to note is controlled oxygen therapy, because with COPD, there is a risk of hypercapnia. And although that's not to say if a person's hypoxic, you don't give them oxygen, because of course it's hypoxia is going to be a lot more severe than the hypercapnia in the complete acute setting. However, at the same time, you do want to titrate the oxygen based on saturations. And then also use stuff like scale 2 for COPD, which is 88 to 92% rather than your traditional 94 to 98. Any questions about that at all before we move on? All right. So we'll move on to our second case now then, which is about a cough. So an 82-year-old female presenting from a care home with a fever and a worsening productive cough for 3 days. I'll give you again about 30 seconds to read through the A2E assessment, and then similar question. What would be some relevant further investigations? Okay, so similar to previous, a lot of the investigations will overlap because we are looking at kind of respiratory in particular. And also there's some kind of hallmark investigations that you would do in your A2E anyway, especially guided by that. Let's have a look at what people are saying. So yeah, chest x-ray, sputum culture. Yeah, big fan of sputum culture. That's something that you will find is really important actually in ED. If you've sent off a sputum culture in a day, in 2 days, you'll be able to actually target what's causing it a lot better. So it's really important to send that sputum culture as soon as you can. Just put it as part of your initial management plan alongside some of the other things you guys are mentioning. So these are some of the investigations that you do straight away in this scenario, and it's fairly similar to the last time. So this is the results that you've got based on what you guys have said. So we've got an ABG there, which is showing an acidotic picture. You've got some blood results that you'll get in a couple of hours' time, and then you've got a chest x-ray. Now, forgive the mouse on the screen, which might be giving away what we're looking at on the chest x-ray, but at the same time, based off that now, that does validate some of the stuff you guys are saying about that kind of sepsis pathway. But in terms of the underlying cause here, what is that chest x-ray showing? Yeah. So you're seeing some kind of right mid-lower zone consolidation, lower zone consolidation. So that would be consistent with a pneumonia, exactly. Now, similar to the previous one, an 82-year-old coming in from a care home with pneumonia is a fairly common presentation that you'll see. So you just need to be able to know what to look out for. And in terms of this presentation, again, the management is based on how you categorize it. So does anyone know how we classify people who present like this in terms of their condition? What is a scoring system that we would use in this scenario? Yeah, a curve 65, exactly. So based off what I've given you so far with regards to the history, the examination findings, and then your investigations, what is the curb score for this lady? I'll show you the next screen as well. I can go back to the last screen as well. So there we go. Okay, so we've got a 3. Does everyone agree with 3? Or has anyone else got any other answers? Okay, so we've got a couple of 3s. I've been a bit sneaky here, actually, and what I've put in is, as you can see on the D section, you've got a V4, which is usually confused speaking. So perhaps that's a bit sneaky, but yeah, what I've tried to get at here is a bit of confusion there as well. That's completely fair if that was not made clear enough. But with regards to the other 3 scores, you're all correct. So you've got um, your urea more than 7 on this screen. You've also got her being 82, and you've also got that diastolic blood pressure being just below 60. So you've actually got a curb for pneumonia in this scenario. Regardless of whether it's 3 or 4, the management would be the same, as each score tends to correspond to mortality risk. So if it's a score of 0, you've got a low risk of death, so less than 1%. 1 to 2 is intermediate, and then 3 or more is high risk. And what that does for us is help kind of guide our management. So with someone with a curb score of 3 or more, what tends to be the management in this scenario? Yeah, so it's a hospital admission. So generally, in terms of the antibiotics themselves, that's as per trust guidelines. But when it comes to management of CAP, I'm a big fan of a flow sheet like this. I think this is from our trust guidelines at UHB. Um, but basically, if you've got that score of 0 to 1, then it's usually home with antibiotics. However, again, you've got to look at the patient holistically in terms of other comorbidities that may be destabilized because of this CAP, or if there's social issues, then you might consider admitting and antibiotics in hospital. Moderate severity is almost like a case by case scenario. So but generally you do admit with a CURB2 and then oral or IV antibiotics, and then 3 or more is IV antibiotics. So our trusted IV Comox with oral clarithromycin, and then I believe it's levo if you're penallergic, levofloxacin. So, and then also, as someone mentioned earlier, you want their microbiological investigations. So sputum cultures are really important. If you've got someone like this lady, you want to get blood cultures as well. And then urgent senior review with ITU consideration. Of course, with ITU consideration, you have to factor in a lot more factors as well, such as the patient themselves, whether they'd be suitable for ITU. But generally, as like a blanket statement, you should consider ITU referral as well. So going back to the patient, as many of you rightly pointed out as well, this patient does have a pneumonia, but it seems like they've got a sepsis secondary to the pneumonia as well. So it's a septic picture you've got here. So the management of it, you want to do your sepsis 6. So you'd want to give fluids, antibiotics, and oxygen. And then I probably should have asked this, to be honest, rather than move into the slide. But then you want to get, catheterization to get accurate fluid input monitoring, blood cultures, and then a lactate as well, which we took a bit earlier on the ABG. And it was 2.43. Yeah, so it was raised, which is kind of what you would expect in a septic picture. Sorry, I know I'm kind of moving forwards and backwards through the slides here. As we mentioned earlier, sputum cultures, viral swabs, and then urine for Legionella as well. And then looking out for atypical pneumonias, they're rarer, of course, but you might see something like hyponatremia and Legionella, or a hemolytic anemia in mycoplasma. Now, saying that, you could have a Legionella pneumonia without the hyponatremia, you could have hyponatremia without the Legionella pneumonia, but it's just something, more for, I guess, textbooks rather than what you'll see. But it's good to look out for, especially in patients who are, immunocompromised or are at higher risk, like often stuff like travel as well. Okay. We'll move along to the third scenario then. This one's a 29-year-old male with a significant smoking history who's got sudden onset chest pain worse on taking a deep breath. And similar to the previous ones, this is your examination findings. So that's a good question. So are the antibiotics given for pneumonia also appropriate for sepsis? So it depends, kind of. If you've got a source for the pneumonia, a source for the sepsis, like you do in this scenario, it's chest sepsis and it's a pneumonia based off that X-ray, then you will give the antibiotics for that. With sepsis, you can give kind of broad spectrum antibiotics if you are not sure. And that, again, is as per the trust guidelines. So often we do give, you'll see people get like Tazocin in the initial management. And then when it's a pneumonia, you can kind of switch that management to Comox and Clary. But again, it's very much dependent on trust guidelines. So it differs where you are. But yes, the antibiotics can often be appropriate. But that's similar for pretty much any infection you'll see when you're working. You'll have antimicrobial guidelines for your trust. So it's best to follow them. And that's a really good question, by the way. So not a naive question at all. Okay, we've already got some answers for the third one. So nice. Yep. So based off the A2E assessment I've written there, do we have signs of tension there? Okay, and what would be some signs of tension that you'd kind of be looking out for in this scenario? Yeah, yeah. So that's the kind of textbook one is you're looking for tracheal deviation because that shows that that air area is pushing it. So with regards to whether there's tension there, also the patient isn't hemodynamically unstable. So that's kind of what you'd also see with a tension pneumothorax, because you can imagine if there's so much pressure of the air building up there, that will affect kind of everything around it as well, and you'll get some hemodynamic compromise. I've got a slide coming up on the tension side of things a bit later. But in this scenario, what we have is, in the absence of tension symptoms, um, we've got an ABG, we've got um, a chest X-ray here as well. So I don't know how well that image is being shown here, but can anyone see what's going on in that chest X-ray? I was reluctant to put this X-ray in just because it might be quite difficult to see, um, especially if the image is being projected as a bit grainy. But yeah, so if you just kind of really peering close, you can see that there's that right side. It actually isn't just lower zone. You can kind of trace it up. You've got that pleural lining there, comparative to the outside, and then you've got a loss of markings past it on that right side, and that kind of extends all the way to the top. Um, there is on the right side. It is hard to tell. I appreciate that. Um, but yeah, so we've got that on the right side there. So that's your pneumothorax, right? And that can be measured. And with regards to management of pneumothorax, I'm conscious of time as well, because we did start a tiny bit late. So I'll just show you the guideline, which I'll read through because I appreciate that this is tiny writing on a screen. But if you once you get the slides, it might be a bit easier to see. So previously, the management of pneumothorax used to be based off kind of the primary or secondary nature of a pneumothorax, as well as being based off kind of the exact sizing of it being a major factor. And now that's kind of changed as per the BTS guidelines in 2023. And instead, we're looking out for high risk characteristics. So, of course, the first one being hemodynamic compromise, which is a tension pneumothorax, which we'll get to in a second, or significant hypoxia, which we don't have in this scenario, bilateral pneumothoraces, which we, again, do not have in this scenario. We don't have underlying lung disease either, and the patient isn't, above 50 years of age with a significant smoking history. Hemopneumothorax, which is usually secondary to trauma. There's no history of trauma in this gentleman either. So what we're looking at is a pneumothorax without the high risk characteristics. And based on that, you can kind of go through the flow sheet and see whether we need to intervene or not. And that can be either through an ambulatory device, which are a new thing, like a pulmonary vent. Sorry, a pleural vent, should I say. That's not available everywhere, and that can be kind of like an outpatient procedure, depending on whether, if the patient's really not keen to have needle aspiration done, then that can be an option. You can often manage it conservatively if, the factors like the size of it, they still use 2 centimeters, so the size of it isn't necessary to intervene, or the patient just does not want intervention, then that's fine. With regards to needle aspiration, that's something that you can do and then see them in a couple of weeks in a clinic to see whether that's done the job. But if it's, a larger pneumothorax or it's causing loads of symptoms, then you go to a chest drain. And then that's kind of like the mainstay of management there. Of course, if we have high-risk characteristics, such as the ones listed there, that's the big red box in the top corner, by the way. I appreciate that was far too small to see and probably the most important thing on the slide, so I tried to, make it a bit bigger on the side, but I'm still having difficulty reading that. So it might just be me. But yeah, that's about that. So, attention pneumothorax. So as you guys mentioned, attention pneumothorax is a medical emergency, even more so than a pneumothorax is. That's something that you've got to do something about right there and then. With regards to the X-ray, if you're lucky, you will never see an X-ray showing attention pneumothorax because it shouldn't happen. The moment that's suspected, you need to try to decompress it. I'm not going to kind of read out the entire, second intercostal space, mid-clavicular line, that stuff that's kind of, you've got to have it down just to say, rattle off the tongue for OSCEs and things like that. But that's how you're going to relieve the tension immediately, and then that's usually followed by a chest drain to try to get rid of the rest of the air. So that's tension pneumothoraces, and I think the diagram kind of shows why you would have that hemodynamic compromise and why it is such a medical emergency. And that tracheal deviation is going to come a bit later, as you said, but at the same time, you tend to, if you've got attention pneumothorax, you will see tracheal deviation as well, and that's one of the signs you'll be looking out for sure. Okay, so let's move on to our next case. Okay, so next up we've got a 58-year-old female who's got sudden onset chest pain, which is worse on taking a deep breath, so similar to the previous case. And I've given a bit of background this time, which whenever you see in any question, in any scenario, you've got to think, why have they put that there? It usually has some sort of relevance. So in this scenario, what would be suspected? I've not asked for investigations there because it's kind of similar to the previous. But what are we suspecting in this scenario? What are we looking out for? Yeah, we would do a last score. Yeah, exactly. So we're looking at a scenario where we need to rule out a PE. Now, what would be a risk factor based on, this history that would make you think of that in particular? There's actually a couple of things there that point towards P being a likely diagnosis. Yep. So you've got your recent surgery, the observations also with your tachycardia points towards that as well. Now, in this scenario, you guys are correct, so it's a PE. So the initial management is guided by hemodynamic instability. Yeah, so recently treated cancer as well. That's one of the criteria on the Wells score as well. So not only do you have a recent hysterectomy, but it was for a cancer as well. So that actually ticks 2 boxes on that Wells score, as you've rightly pointed out. So that's the Wells score, and now it's quite easy to hit 4 just because any alternative diagnosis being less likely than PE, like it is in this scenario, would mean that you would score a 3 there. But the initial management is based off whether they have hemodynamic instability. So persistent hypotension, obstructive shock, or cardiac arrest. And then in these scenarios, you're looking at thrombolysis with something like alteplase, But if there's no hemodynamic instability, the risk is assessed using a Wells score. For this lady, do we have hemodynamic instability? Yeah, so based off that definition that we talked about a bit earlier, we actually do have hemodynamic instability here. So we would consider thrombolytic therapy. Of course, it's with senior support, and often there's kind of contraindications to that, which I may have included in the next slide, but I may not have. So if I haven't, I'll come back to it. And then if not, then you do your Wells score. If we were to do a Wells score on this lady, what would the score be? Based off the information we know. So, of course, we don't know if she has hemoptysis or not, so we can't give her the point there. Trying to figure it out myself. 4.5, 5.5. We've got 7 here. That's correct. So, actually, 4.5. Yeah, 7. That is correct. So regardless, we would be doing, a CTPA and giving therapeutic, usually a low molecular weight heparin, or in some places you give a DOAC in the interim. So these are kind of the investigations that you'd be looking to do in this scenario. So an ECG will show most likely sinus tachy, although I have seen just a couple of weeks ago, I did see a S1 Q3 T3, which was quite cool. But generally, you will see sinus tachy. The D-dimer will be elevated, although in this scenario, the D-dimer isn't the most reliable source of information. Does anyone know why that might be the case? Yeah, exactly. So a recent surgery, recent malignancy, basically the D-dimer can be raised by a lot of things. Although with the rise of 7,600, you definitely would be considering some sort of clot. However, at the same time, you can get D-dimers like that from, a recent surgery or a recent malignancy. Infection can also often raise a D-dimer. And another important thing that you'll probably find a lot in your practice is that you will find a lot of D-dimers being raised and, Dopplers being done and things like that. But infection can also raise a D-dimer. So D-dimer is very, very kind of non-specific, but the guidelines do say, especially if that Wells score is below 4 and you've got an elevated D-dimer, you should consider CTPA. So it's important to do, and it's just something that should be in your management plan. A bedside echo would show raised right heart filling pressures. That's just because of the strain being put on the heart. And then with regards to that CTPA right there, that's probably the most kind of classic image that you'll see. What is that called? Does anyone know what that's called? Or what we're even kind of looking at there? Yeah, so that's a saddle embolus, which is characteristic of a massive PE, basically. So that's what we're seeing in this scenario as well. So, with regards to the management of this, for this lady, you would be looking at likely just anticoagulating her. In terms of thrombolytic therapy, there are quite a long list of contraindications for it as well, which are important to know. I don't think I've included it, but I'll comment on it at the end then. But we'll move on. What are we looking at time-wise? Okay, got a couple of minutes left. So these are some presentations which weren't mentioned earlier in the introduction section as part of the UK MLA guidelines. UK MLA curriculum. But these are something that you should be looking out for as well. So you've got pleural effusions. So what you can see in the first X-ray, you've got a larger left-sided pleural effusion and then a smaller right-sided one. The reason it's probably not in respiratory emergencies is because regardless of what you do, you will have to take a tap, take a sample, and then send it off. And then that might take some time. And often it's secondary, or it is secondary to something else. And then, in terms of exudates, you'd get that because of an infection or a malignancy or anything like that, or a P, in fact. And then with regards to transudates, you'd get that because of renal causes or cardiac causes. So stuff to do with actually the volume. In terms of pulmonary edema, again, that's probably not in that emergency section, just because, although I do think it is, especially on cardiology right now, the management for that being, what would be the management for pulmonary edema, actually? I'm just talking a lot now, I've just realized. So if someone wants to tell me the management for pulmonary edema, or like kind of the mainstay of management, I know there's other things as well. But yeah, so IV diuretics. In terms of causes for pulmonary edema, you're looking at heart failure being quite a common cause, and then you're looking at diuretics as well as optimization of that heart failure management. Another thing that you'll see often, depending on where you're working, is infective exacerbations of things like ILD, bronchiectasis. The only difference that you need to keep in mind with regards to bronchiectasis and ILD is they can be caused by kind of more uncommon bugs. And the management for these infective exacerbations often involve prolonged courses of antibiotics. So instead of your standard 5 days or 7 days for bronchiectasis, you tend to give 2 weeks of antibiotics due to their chronic changes. And again, you'd want to get respiratory input whenever you're managing conditions like that. And then finally, I've just popped this one in at the end because the session is called Respiratory Emergencies, and anaphylaxis tends to present in its hyperacute form as a respiratory issue because, well, the patient is struggling to, breathe in these scenarios. So it's something to kind of always have in mind as well. And that also feeds into that ALS algorithm stuff we were talking about a bit earlier with respiratory failure. So I think that's about everything. Timing wise, we are looking good as well. So with that in mind, I think that's about everything. I've got a nice feedback slide at the end. And I think this is the QR code. So if everyone could just fill in a quick feedback form, I would really appreciate that as well. And with that, if there's any questions, feel free to drop it in the chat as well.
Yeah, I just want to let everyone know as well. I've put the feedback form in the chat, so you get all the feedback from that, Waleed, as well.
Yeah, excellent.
And certificates will be handed out to everyone who attended as well. So, yeah, thank you all for attending, and thank you, Waleed, for the lecture. It's actually really informative. I've even learned some stuff as well. I've actually got ED as my next rotation, so that would be really useful. So thank you.
No, that's great. Thank you. What do the black dots and arrows on the last RHD image indicate? So I'm assuming that's just looking at that's interesting. It is just a congested kind of pulmonary edema picture, and pulmonary edema X-rays often have that kind of congested picture with that fluid in the fissure. but I don't know what the arrows are actually specifically pointing to. I'm assuming it's just like the patchy white parts, which are kind of the fluid, giving it the congested picture in the absence of anything else. Have you got any idea what they might be referring to in that
I,
scenario?
I think just to add, is it? I can't see it well enough, but they look like air bronchograms, but I'm not too sure.
Yeah, potentially.
It's very difficult to discern though exactly what it is because they're in kind of like areas where there's a divide between the hyperdense and hypodense. You know what I mean? There's kind of weird areas they're pointing
Yeah,
to, so I'm not too sure myself.
no, I think you might be right. I've had to kind of zoom in 100 times into the screen and then completely peer in. So that's what my camera is showing right now. But yeah, I think so. It may be. It may be.
Either way, that patient definitely has some level of pulmonary edema.
Yeah,
We can say that for sure. So
probably for a furosemide infusion in that scenario, I'd say,
yeah.
rather than just some doses. All right, excellent. Any other questions at all?
I think that's it from the chat, to be
Yeah.
honest. But yeah, that thanks again for, as I said, for the really useful session. I hope you guys had some use from it on a Friday night. I know it's probably not ideal on a Friday night to be, in a teaching session, but I know finals are coming soon, so hopefully it'll be useful to you and you've learned something. And yeah, thanks again, Waleed.
All right, excellent. All right, thank you, guys.